Greetings, everyone. This is Steve Cole with your PARM 2223 lecture for Unit 13 on adrenal issues and Addison's crisis. So let's jump right into it. So what we're going to do, one of the reasons why we need to talk about this is one of those really rare conditions that if you don't have at least understanding that exist and the proper treatment can actually be fatal. And it's one of those conditions that can be kind of confused for other things as well. So that's kind of where we're going at with this. So we're going to talk about the pathophysiology of primary and secondary acute adrenal failure, not renal failure, but adrenal failure. We're going to talk about Cushing's syndrome a little bit. We're actually going to talk about, and actually we're not going to talk about in this lecture, we're going to talk about a different one, but we're also going to talk about the clinical presentation of that patient with Addison crisis or Addisonian crisis may present with, and we're going to talk about some of the optional treatment modalities, especially in the pre-hospital setting. So let's jump into it. So adrenal emergencies in the pre-hospital field, they're kind of rare, or actually they are really rare. I think I've only actually seen one true adrenal crisis in 20 some years. But I've seen more than a few patients that have a history of Addison's, right, or similar conditions. And I think the biggest problem that we have is that we don't, this is one of those lectures that we probably fell asleep during. We barely squeak by. We don't pay a lot of attention to, and I understand it compared to the instance of cardiac arrest, MIs, STEMI, stroke, sepsis, and a million other things. This is pretty far down on the occurrence list for us. But it's kind of like Guillain-Barré and some of these other conditions we've talked about where if the patient has it, it is absolutely front and center in their list of shit I have to worry about and shit they expect the healthcare provider taking care of them to be familiar with. So I'm going to bump it up a little bit on our important stuff list right now. So patients may refer to this by different names. They may say they're cortisol dependent or steroid dependent. And when they're talking about steroids, they're not talking about the Hulk Hogan, Arnold Schwarzenegger type of steroids. They're talking about glucocorticosteroids like the Solumetrol that we carry in our kits. They may say they have pituitary dysfunctions. They may say they have Addison's disease. They may say they're adrenal deficient or they have hypercortisolism, which is kind of weird. All these different conditions, but the presentation and the treatment are very similar. So how often does this occur? Well, like I said, I've only personally seen maybe one that I knew of at least, true Addisonian crisis, adrenal insufficiency in a number of years, but I've had a number of patients with this in their history, with this in their list of medical conditions. Just wasn't a crisis when I was dealing with them for other stuff. But certainly is something that they were very familiar with because the stuff I was dealing with as a pre-hospital practitioner could trigger it. So for them, this is pretty high on the list of, oh crap type situations, for them at least. So most often, this is actually due to something called steroid withdrawal. Now, it was really interesting when we first started carrying steroids and getting it for COPD. It was interesting. I didn't give it much of a thought, but as my education increased and as I kept coming across it, glucocorticosteroids have a lot of multi-system derangements they cause and a lot of different implications across the entire body that was really quite stunning to me the more I dug into it. And it is, when patients say they got a single dose of steroids, they felt like crap, I absolutely get it when you dig into all the different things this does in the body. This is truly a part of the body's response to stress, so it's something we need to be aware of. Approximately 6 million patients out of 350 to 370 million people in the United States, about 6 million, which is not insignificant, are considered to have undiagnosed adrenal insufficiency to one degree or another. It's on a spectrum, and which they normally don't have. They don't worry about or pay much attention to until they undergo a time of physiological stress. So this would be the pre-hospital emergency where they get into a car wreck, or when they have an MI, or they have surgery, or they have some other crisis that tips them over the iceberg. Now, it's easily treated if you know about it. But the mortality of it is pretty high. And that's where we come in. So when we talk about the mortality, one of the things that first started really getting me interested in this was in 2010, In the Journal of Paramedic Practice, there was a case report of an ambulance that went on a patient who had a true legit adrenal crisis, and she's begging for hydrocortisone therapy. This was in the UK, if I remember right. She's begging for steroid therapy, and of course the crew like, steroids for, something's wrong, but you're freaking nuts, and they did give it, and they didn't call medical control about it, anything like that. And they weren't comfortable with it. They weren't familiar with the condition, or they'd forgotten about it, whatever. And as a result, the patient did not die, but it was highlighted as a key part of her morbidity. There's another study in 2009 that also pointed out that most healthcare providers, nurses, medics, whatever, are very unfamiliar with this condition. And as a result, if they're unfamiliar with it, they're less likely to do appropriate intervention. So that's, again, takes us back to the reason for this lecture, is to make you more familiar so you're more likely to do something with it. Let's talk about a little bit of pathophysiology. So adrenal insufficiency has been around forever, probably for as long as humans have. But it's first actually given a name and identified and kind of prioritized as a medical condition in the 1840s by Thomas Addison. Not Edison, Addison. Kind of a shocking discovery. It wasn't Thomas Edison, but I'm for paying attention. Anyway, but unfortunately, even after he discovered it, and you can actually find, if you want to go dig into it, some of the case reports of how this would present, and these patients would waste away and die in a fairly rapid order, up until about the 1940s. Now, I never found a clear pathways to how they figured out that glucocorticosteroids were the solution to this, but somehow they did. And it started in the 1940s. Patients that had almost 100% mortality before they reached adulthood started surviving. And so they identified adrenal insufficiency, and corticosteroids became kind of a mainstream. And then we started seeing corticosteroids used for other inflammatory conditions, including rheumatoid arthritis, and other which was obviously very painful, and other conditions as well, emphysema, COPD, so on and so forth. Think about all the different things that glucocorticosteroids are in, such as Advair. There was used to be another powdered inhaled treatment for, I can't remember what it was now, treatment for COPD and asthma. That was also an inhaled steroid. That, again, this is one of the main causes today of adrenal crisis. Now, adrenal insufficiency, they can call it primary, secondary, congenital, or acquired. And it's pretty simple. When we look at the etiology, adrenal insufficiency refers to a deficiency of the adrenal gland. Now, the adrenal gland sits on top of the kidneys. It actually secretes epinephrine, right? Hence, adrenaline. Adrenal, of course, means on top or next to the renal system. It's responsible for the fight or flight, but also produces stress hormones, cortisol and aldosterone. Cortisol is responsible for fighting inflammation. It's also responsible for helping us fight our hypotension and stress response. We already mentioned that. Now, the adrenal cortex itself has a fairly significant amount of epinephrine and other hormones in it as a functional reserve, so that we can dump it rapidly when needed. And this is normally called on the body when it needs it in times of surgery, trauma, stress, serious infection, sepsis. This is where our response to dying largely comes from. This is where our heart rate increases, our body becomes sweaty, our vasoconstriction occurs. It all originates from the hormones that are excreted in times of crisis from the adrenal gland. Now, mineralocorticosteroids or glucocorticosteroids are hormones that are responsible for it to help supplement the release of this, and without them, our body does not respond to shock very well. What's interesting, if you work in a system that uses esmolol, which is It's part of a lot of agencies' RSI protocol. It is a is not a dissociative in that it does not cause dissociation in the way that ketamine does, but it is a sedative that is used in largely the same place as ketamine or propofol will, in addition to a paralytic. And one of the bigger problems with esmolol, and one of the reasons why it's fallen out of favor, even though it's still widely used, is that it suppresses the shock response if they are septic, or especially in pediatrics, it's a dose-dependent response. And of course, the solution to that is to give a stress dose of glucocorticosteroids, which you'll see us do here for adrenal crisis as well. So cortisol helps the body respond to stress. It helps us maintain our blood pressure. It helps slows the systemic inflammatory response, what we call SEERS. Now you may think, but wait a minute, why don't we just give steroids whenever they develop SEERS? Well, because it's a mixed bag. It slows the inflammatory response, but also makes us more vulnerable to certain infections, particularly fungal infections. So it's kind of weird. It helps balance the effect between that of insulin breaking down sugar for energy. So it helps mitigate that. And helps mitigate, or not mitigate, but moderate metabolism for carbohydrates and fats. Helps smooth it out. So the problem when we get to Addison's disorder is that Addison specifically is a dysfunction of the whole adrenal system. And as such, when the body goes under stress, it doesn't respond appropriately. Now we look at adrenal insufficiency, primary versus secondary. It's pretty much what you see in everywhere else. Primary adrenal insufficiency is something that's specific to the adrenal gland. Secondary insufficiency is something that's from something outside the adrenal gland. So again, in the United States, 80 to 85% of these are caused by autoimmune destruction of the adrenal gland, which would be a secondary insufficiency. A substantial portion is also caused by steroid use. Specifically, like, for example, somebody who's on steroids for rheumatoid arthritis or for COPD, and then either through misfortune, a financial crisis, or just pure stubbornness, they decide to suddenly stop it. Steroids, if you're on steroids, I want to say it's close to 2 weeks, you develop a physiological dependence and have to be weaned down. And the taper, they call it the taper for steroids, is very specific. And they are very specific because if you taper off inappropriately, such as suddenly stop, then you can actually develop Addison's crisis as a result of that. Some other causes, one of the interesting things is tuberculosis, granulation of the tubules in the nephrons from tuberculosis. Very similar. We normally think of tuberculosis as a respiratory disease, but it's a multi-organ disease. So in developing countries, tuberculosis is the most frequent cause of Addison's crisis, as if they don't have enough to deal with. Let's see, we talked about that. So tuberculosis is the most frequent cause of adrenal insufficiency in developing countries and underserved populations. What do you think we mean by underserved populations? Think about that. If you go out today in an urban or a rural environment and you were to serve deal with an underserved population, who do you think that would be? Well, when I think about it, I think it'd probably be the homeless population, or the extremely impoverished, or perhaps those that are on the Indian reservations or other populations like that, or even, for example, those who are in the prison system sometimes are at increased risk for TB, and so on and so forth. Now, secondary adrenal insufficiency can be due to hypofunction due to lack of adrenocorticotropic hormone and other misfunctions of pituitary gland, often due to pituitary cancers. And what's really interesting is the way they handle this. They will actually go in through the nose. They'll knock you out. Go in through the nose. Take out a square portion of the base of the skull that separates your sinus cavity and your cranial vault. Go in there, kind of where you see the arrow right there, and actually do surgery around the pituitary gland and remove and remove the tumor itself. If you've ever seen that, it's really creepy to actually watch. There's tons of videos on it. Incidentally, if they have an event within 2 to 4 weeks of this, that's an absolute contraindication for nasal pharyngeal airways or nasal tubes or anything of the like, because they're the only case. You always hear how, well, we can't do a nasal tube in head trauma because the tube might go in their brain. Well, there hasn't been a case of that, except in cases where they had this surgery done within 2 weeks before, and there is a couple cases of it in that case, because the palate, not the palate, the portion where they have gone in to secure the tumor is still weak and becomes a path of least resistance. Adrenal hyperplasia. This is congenital adrenal insufficiency. So what this basically results is a decreased level of cortisol and an increased level of androgens, male sex hormones of both sexes. These people that may have inappropriate hair growth and other anatomical differences that may cause their gender to be misdiagnosed. They also develop more brittle bone age and hyponatremia as well. This is largely treated with various hormones, male testosterone blocking hormones, which of course come with their own problems as well. But again, steroids are a primary cause. Now, we use steroids for lots of things: lupus, arthritis, asthma, COPD. They're used in organ transplantation, so on and so forth. So, about when they undergo severe stress, obviously that's a risk factor for Addisonian crisis. About 60% of the severe stress is septic shock in nature. Don't really talk about much, but just to give you an idea of the importance of steroids, there's actually a pretty strong push, or has been in the past, not too long ago, for what they call VSC therapy in cardiac arrest, and this is completely unrelated to the the Addisonian crisis discussion. But VSC is vasopressin, steroids, and epinephrine. And there's a group of people, very smart people, that are pushing for this to replace standard epinephrine therapy. And the research in it has actually been fairly positive, but the research hasn't been extensive, and therefore the AHA hasn't jumped on board with this yet. I don't think they're going to anytime soon, unfortunately, because I haven't heard of any new research on this. But if you hear about VSC therapy, it's not vasopressin alone or epiurone or steroids alone. It's the combination of the three. So the early stages of Addison disease are similar to, will look like depression or the flu, or maybe just, kind of an early sepsis. That would be fatigue, lethargy, muscle weakness. You also have some weight loss, very similar to many other conditions. This could easily be mistaken for maybe they have some hyperglycemia because they have to urinate frequently and increased thirst, but also have increased craving for salty foods, not just any foods, but salty foods, because often these patients will be hyponatremic as well. There's an example what the darkened skin may look like. You see some examples there. You also see, these are some other abnormal skin presentations that you will see there. Darkening of the palms and what they call hyperpigmentation of various regions. Yeah, is what it is. I don't expect you guys to go digging for this, but there you go. Now, when they start getting Addisonian crisis, well, they'll develop, again, you look at these conditions and you can think, okay, especially if they're hypotensive, this is sepsis, or this is some other cause of hypotension and shock. The key, though, is the recent history, or the history of glucocorticosteroid use and maybe stopping it, right? Or a history of Addisonian crisis. So what do? Well, we still, the good thing is we're not making an either or choice. We're not making a choice to treat adrenal insufficiency with steroids or treat the hypotension with fluids and vasopressors. You do both. So the good news is that you get to treat both of them. You just add steroids on if you think that's that Addisonian insufficiency is a cause. So when we look at adrenal insufficiency versus an adrenal crisis, well, the crisis is always acute onset, and it always has a precipitating factor. So there you go. Now, 1/3 of adrenal crises occur outside the home, and flu-like symptoms, nausea, vomiting, diarrhea, account for most events because in the case where it occurs, sometimes because they have GI symptoms, it interferes with their absorption of their daily prescribed medication to include steroids and such. Lots of triggers, as we already talked about, even arguing in extreme cases, the flu, GI upset, auto accidents, surgery, trauma, etc. Now let's talk about treatments. So keep in mind that steroid therapy, even though we're going to talk about it a lot, is just a bridge therapy. It's not definitive. If you have a patient with a history of Addison's crisis, you should have a very low threshold to actually give stress dose steroids. Even if, let me back up, in the patients that have a specific history of Addison's crisis that's already been diagnosed, the chance of them developing adrenal crisis in addition to whatever's going on is fairly high anyway. So you're getting ahead of it. Now, if they don't have a history of it, but they have a history of all the other risk factors, taking steroids, suddenly dropping off, so on and so forth, you have a fairly strong case. If they don't have either of those histories, well, then I'd be a little more cautious. Your overall strategy is basically what you do for septic shock, and you add steroids to it. That's it. So you treat the adjacent conditions simultaneously, and you treat them the same. Now, when we talk about stress dose of glucocorticosteroids, this is it makes it sound like you're given a huge amount. And in reality, that's not the case. These are actually the normal pre-hospital doses. So when I first started reading about stress dose glucocorticosteroids, I started thinking about the old days when we used to give these uber high doses of Ciumedrol to patients with spinal cord injury. And those were huge doses, 30 milligrams per kilogram. No, this is nowhere near that. This is your normal pre-hospital dose. They just call it a stress dose of glucocorticosteroids. So if you're carrying hydrocortisone, your normal dose is usually 100 milligrams. So that's what you're going to give. If you normally carry Ciumedrol or methylprednisone, which is what most services I'm familiar with carry, not all of them, but most of them, then your normal dose is 125 to 250 milligrams. That's probably what you're going to give for a stress dose for Addison's. If you carry dexamethasone, your normal dose is 48 milligrams IV, IM, or IO every 12 hours. This also, especially if you deal in high altitude situations where you deal with HAPE and HACE a lot, you may carry this instead of Ciumedrol, but that's the same dose you're giving for stress dose adrenal response. Now those are glucocorticosteroids. There are also mineral corticosteroids, but those are given as adjunctive therapies, not emergently, typically. You also give fluids, and this fluid is very similar to what you'd give for fluid challenges. This is the one time that saline is actually preferred because of its salt content. There may be cases where, in contact with a physician, he may actually order you to give bicarbonate as well, but you're giving it not for the buffer, but for the sodium loading effects, very similar to what you do for tricyclics. Now, because this has an effect on the renal system, especially with tuberculosis, you may also see, in addition to hyponatremia, you may see hyperkalemia. So you need to be cognizant of that. Again, another reason to look at your EKG. So your treatment for for hyperkalemia is calcium, whether it be calcium gluconate or calcium chloride with bicarbonate. If you happen to work in a critical care agency, you might also be given an insulin drip with additional dextrose on top of it. If you're doing an interfacility transfer, they may be given KLX8 or Lasix, although that's really fallen out of favor. and albuterol. Now, albuterol for hyperkalemia, we talked about this in the last unit, where albuterol is the first-line treatment for hyperkalemia because of its rapid onset. Now, it's a transient. It's only good for about 2 hours, but you usually see the effects within 30 minutes. And also, this could be a reason for emergent hemodialysis. So we already talked about that to death. Hyponatremia. Again, you may actually have to do transport with hypertonic saline. So, now, what are the pitfalls? What's going to get you in trouble with this? Well, the biggest thing is just simply failure to recognize. So anytime you hear a patient that has Addison's crisis, adrenal insufficiency, they're steroid dependent, or a patient who is on steroids and has suddenly stopped for some reason, or the third one is they're on steroids but they have a sudden onset of acute illness, you need to consider that perhaps they have an adrenal insufficiency, and that's the proximate cause of their hypotension and so on and so forth. Now, this is also especially true in any patient that appears to be septic, because this is a classic sepsis mimic. If you look at the fever and you look at the hypotension and the presentation, it's a classic sepsis mimic. And also, there's nothing that says that they can't exist at the same time, because sepsis can be a precursor. So that pretty much finishes up this week's lecture, and thank you for your time. And if you have any questions, go ahead and pop them into the ungraded discussion board. Thank you.